So, I want you to try a quick visualization exercise for a second. Just picture a typical stroke patient in your head.
Right, and chances are you're picturing someone a bit older, like maybe a 68-year-old with a long history of high blood pressure.
Yeah, exactly. Maybe they're taking a handful of pills every morning or, dealing with irregular heartbeats like atrial fibrillation.
Which makes perfect sense. I mean, that clinical picture represents the vast majority of stroke cases you're going to see in any neurology ward. It is literally what our medical systems are designed to treat.
But for this deep dive, we are going to completely shatter that image. I want you to imagine you're walking into a hospital room and the stroke patient sitting in the bed is 25 years old.
Wow.
Right. They run marathons, they eat a perfectly balanced diet, their blood pressure is ideal, there is absolutely nothing visibly wrong with their health. So what do you even do with that?
Well, you basically have to throw out the standard diagnostic playbook. When a healthy 25-year-old suffers a stroke, we aren't dealing with the usual wear and tear of aging on the vascular system.
No, not at all.
We are suddenly in the realm of medical mystery, looking for invisible culprits hiding inside the blood itself.
And that is exactly what we're unpacking today. We're diving into a medical case file and teaching guide titled Hypercoagulable States and Stroke in Young Patients.
It's a fascinating look at these rare situations.
It really is. The goal of this deep dive is to explore the science of hypercoagulable states, basically situations where young, seemingly perfect specimens of health suffer devastating strokes because their blood chemistry has fundamentally changed.
Right, it's a chemical problem.
Yeah, and I actually like to think of the bloodstream as a major highway system to help visualize this. Usually a traffic jam, which is our stroke, right, a clot blocking blood flow, happens for very obvious reasons.
Like bad roads.
Exactly. Maybe the roads are terrible and full of potholes, which would be plaque buildup. Or maybe a car engine just explodes on the highway, representing a heart issue that throws a clot.
But in these young patients, the roads are freshly paved. The cars are brand new.
The infrastructure is totally sound.
So if the highway is clear and the cars are fine, the only explanation for a pileup is that something is wrong with the driving conditions themselves.
Right. We are looking for an invisible oil slick covering the highway. The blood is chemically eager to clot, practically looking for an excuse to coagulate.
And to find these oil slicks, we first have to figure out if it's a primary condition, so something the patient was born with, or a secondary condition caused by an external trigger.
Let's start with what you're born with, the genetic suspects.
Yeah, these are known as inherited thrombophilias. Some of the most common ones you'll hear about are antithrombin deficiency, protein C and protein S deficiency, and a genetic mutation called factor V Leiden.
Which causes something called activated protein C resistance, right? Now, those names sound incredibly dense, but if we break them down, it's really just a story of missing breaks.
That's a great way to put it.
Because your blood is always performing this delicate balancing act. You have proteins that trigger clotting to stop you from bleeding to death if you get a paper cut, but you also have proteins acting as the brakes to stop that clot from spreading through your whole body.
Right, and that is the exact mechanism here. Protein C and protein S, for example, are literal enzymes that circulate in your blood. Their entire job is to seek out and dismantle active clotting factors.
So they are the biochemical brakes.
Yes, if you were born with a genetic mutation, that means you just don't produce enough of them. Or if you have factor V Leiden, which alters a clotting factor so the brakes can't grip onto it, your body's clotting cascade can just spiral out of control.
And from the source material, it seems doctors usually know to look for these genetic missing breaks when they see specific red flags in a young patient.
Definitely. Like if a young patient has recurrent deep vein thrombosis, so DVTs in their legs.
Or if they get clots in unusual places,
Yeah.
right? Like the veins of their liver. Or just a strong family history of clotting at a really young age.
But, and this brings us to a massive clinical plot twist, while those genetic conditions absolutely cause clots, they overwhelmingly affect the venous circulation, the veins.
Right.
They are huge players. If a young person gets a blood clot in their calf after a long flight, for example,
But a stroke is an arterial problem. It's a blockage in the high-pressure arteries feeding oxygen to the brain.
Yes. And the role of those specific inherited thrombophilias in causing arterial ischemic strokes is remarkably small.
Yeah.
They aren't the primary villains causing blockages on the arterial side of the highway.
Okay, which means we have to look for the major exception, the genetic oil slick that absolutely does target the artery.
And that is antiphospholipid antibody syndrome, or APS.
APS.
Yeah, in young patients, APS is one of the most critical things to rule out because ischemic stroke is actually the most common arterial event associated with it.
So what's actually happening in the body to cause this? Because from what I understand, it's basically an autoimmune issue.
It is, yeah. So in a healthy immune system, your antibodies are like heat-seeking missiles, right? They're programmed to attack viruses and bacteria.
Right, the bad guys.
But in APA, the body produces rogue antibodies that mistakenly target normal proteins bound to phospholipids, which are just the fat molecules that make up the outer membrane of your own cells.
Oh, wow. So it's friendly fire.
Exactly. And this friendly fire creates a highly inflammatory, profoundly pro-clotting environment all along the lining of the blood vessels.
And it comes with some very distinct, severe symptoms, doesn't it?
It does. You see recurrent arterial or venous clots, but also devastating reproductive issues, like recurrent fetal loss. And there's a highly specific skin condition called levato reticularis.
Levato reticularis, what does that look like?
It's a fascinating diagnostic clue. It presents as this purplish lace-like or net-like pattern on the skin, typically on the legs.
Because of the clots.
Yeah, because APS causes these microscopic blood vessels to spasm and clog up with tiny clots. The deoxygenated blood essentially gets trapped. It pools in the skin, drawing this very visible mottled pattern.
Wow. So a doctor spots that skin pattern, hears the patient's medical history, and suspects APS.
Right.
But to actually confirm the diagnosis, they have to test for specific antibodies like lupus anticoagulant, anticardiolipin, or anti-beta-2 glycoprotein.
Correct.
But here's the catch from the case file that really shocked me.
Yeah.
You have to confirm these high antibody levels on 2 separate occasions, exactly 12 weeks apart.
Yes, that's the standard criteria.
I mean, if you are sitting there as a 25-year-old who just had a stroke, 12 weeks feels like an agonizing amount of time to wait just to get a name for your disease.
Oh, it is an incredibly anxious waiting period for the patient.
Right.
But that strict 12-week window exists for a very important biological reason.
Okay, why?
Because the immune system is highly reactive. If you catch a random viral infection or even just a severe bacterial bug, your immune system revs up to fight it. Yeah. During that normal immune response, it is actually quite common for the body to transiently produce low levels of these exact same antibodies.
Ah, okay. So if a doctor tests you immediately after stroke and the antibodies are there, it might just be the temporary aftermath of a nasty cold you had 2 weeks ago.
Exactly. If they test you again in a month and those antibodies are gone, it was just a transient spike. It wasn't APAS.
Right.
The 12-week window is the medical threshold to prove that this immune dysfunction is chronic and persistent. You have to prove the oil slick is a permanent feature of the highway, not just a temporary spill from a passing storm.
That makes total sense. You want to be absolutely sure before you commit a young patient to lifelong blood thinners.
Definitely.
Speaking of which, the standard treatment for an arterial clot in APS is usually aspirin or moderate-intensity warfarin. But there's a massive caveat here regarding warfarin if the patient happens to be pregnant.
Yes, it is a critical red line in pharmacology. Warfarin is deeply teratogenic.
Meaning it causes birth defects.
Right, it severely disrupts fetal development.
And since a huge demographic for APS is women of childbearing age, that's a major conflict. If a patient is in their first trimester of pregnancy, they absolutely cannot take warfarin.
No, they can't.
But obviously you can't just leave them unprotected from a catastrophic stroke either.
So you have to rely on a substitute. During the first trimester, doctors will transition the patient to low molecular weight heparin or unfractionated heparin.
And why is heparin safe when warfarin isn't?
It all comes down to molecular size. Warfarin molecules are small enough to pass through the placental barrier and reach the fetus.
Oh, I see.
But heparin molecules are physically too large. They literally stay in the mother's bloodstream, providing the anticoagulant protection she needs without ever crossing over to harm the developing fetus.
The mechanics of that are so elegant. Just using molecular size as a physical shield.
It is pretty remarkable.
All right, let's pivot a bit. We've talked about conditions you're born with or these chronic autoimmune states. But what if a young patient's blood isn't inherently prone to clotting? What external triggers secondary states can suddenly hack the system and turn perfectly healthy blood into sludge?
The list of secondary hypercoagulable states is pretty broad. We are looking at conditions like nephrotic syndrome, polycythemia vera, essential thrombocythemia, heparin-induced thrombocytopenia, malignancy, and oral contraceptive use.
Okay, there is a lot of medical terminology there, so let's quickly define the landscape for you listening. Polycythemia vera is basically the bone marrow going rogue and pumping out way too many red blood cells, right? So
Yes.
the blood literally becomes too thick and viscous to flow properly.
Yeah, the sheer volume of cells creates physical traffic jams. And essential thrombocythemia is similar, but with platelets, the tiny fragments that initiate clots, the body just makes too many.
Right. And nephrotic syndrome.
That's a kidney disorder. The kidney's filtering system breaks down, and the patient essentially urinates out their body's natural anticoagulant proteins, so they lose their natural brakes.
Oh, man. And then there's heparin-induced thrombocytopenia, or HIT, which is perhaps the wildest paradox in this whole file. Heparin is a blood thinner meant to stop clots.
Right.
But in HIT, the patient's immune system freaks out at the medication and triggers a massive system-wide clotting cascade instead.
It is a terrifying paradoxical reaction.
Right.
But among all these secondary triggers, two of the most significant to explore in depth are malignancy, so cancer, and oral contraceptives.
Let's start with cancer. The idea that a stroke could be the very first symptom of a completely undiagnosed tumor is chilling.
It really is.
How does a tumor located in, say, the lungs or the pancreas cause a stroke all the way up in the brain?
Well, cancer fundamentally alters the body's chemistry to serve its own growth.
Hmm.
And one of the ways it does this is by triggering a low-grade state of disseminated intravascular coagulation, or DIC.
Okay, what does that mean in practice?
Tumors can secrete substances called tissue factors directly into the blood. This essentially tricks the entire circulatory system into turning on the clotting cascade simultaneously.
It's like a building's fire alarm system, glitching and turning on every single sprinkler in the building, even though the fire is only in one tiny room.
That is a perfect analogy. You end up with thousands of microscopic clots floating around, eventually making their way to the brain.
So that's the chemical mechanism. But there's also a brute force physical mechanism, right?
Yeah, tumors require a massive blood supply, and their structure can be very friable or crumbly. Literal physical fragments of the tumor can break off into the bloodstream, travel up the carotid arteries, and lodge in the brain's vessels.
Acting as a tumor embolus.
Exactly.
And then there's a third pathway, which sounds incredibly bizarre. Non-bacterial thrombotic endocarditis.
Right. So usually if a patient has growths on their heart valves, we assume it's endocarditis caused by an infection bacteria setting up camp and growing on the valve tissue.
Right, like strep or something.
But the hypercoagulable state created by cancer is so intense that sterile mats of platelets and fibrin will spontaneously start clumping together on the heart valves.
Wait, sterile, no bacteria involved at all?
None. Just sticky blood forming precarious clumps that eventually tear off, enter the arterial highway, and shoot straight to the brain.
That is wild. It highlights just how aggressive cancer is at manipulating the body's environment.
Yes.
But let's shift gears to a secondary trigger that is vastly more common in young women, and something many of you listening might have personal experience with: oral contraceptives.
This is an area where clear communication of risk is absolutely vital.
Because when you look at the clinical data, there is a statistic that jumps right off the page. Oral contraceptives cause a roughly 9-fold increased risk of thrombotic stroke.
Yes.
I mean, if you are listening to this right now and you take birth control pills, hearing 9 times the risk of a stroke probably induces a mild panic attack.
Understandably so.
First, let's talk about the how. How does a pill designed to prevent pregnancy cause a blood clot?
It comes down to how the liver processes hormones. Most oral contraceptives contain synthetic estrogen. When that estrogen hits the liver, it essentially acts as a chemical signal, telling the liver to crank up the production of certain proteins, including coagulation factors like fibrinogen. Okay. At the same time, it tells the liver to dial down the production of antithrombin, which is one of our body's main anticoagulant brakes. So you have more clotting factors and fewer breaks.
Okay, so the chemistry definitely shifts toward clotting, but let's deal with that terrifying 9-fold statistic. That number sounds huge.
We have to separate relative risk from absolute risk here. The relative risk, the multiplier, is indeed around 9-fold in some studies.
Okay.
But to understand the actual danger, you have to look at the absolute baseline risk. For a healthy 20-something woman who doesn't smoke and has normal blood pressure, Her baseline risk of having an ischemic stroke on any given day is astronomically low. It is an exceptionally rare event.
I think the best way to visualize this is a lottery analogy.
Oh, let's hear it.
If my chance of winning a massive jackpot is 1 in 100 million, and I decide to buy 9 tickets instead of 1, I have technically increased my chances ninefold. My relative risk of winning is 9 times higher.
Right.
But my absolute chance of actually winning the jackpot is still basically 0.
That math checks out perfectly. And when we look at population data, the absolute numbers confirm this.
What do the numbers say?
You would need to prescribe oral contraceptives to roughly 24,000 healthy young women for an entire year to cause just 1 additional ischemic stroke.
1 in 24,000. See, that provides so much necessary context.
It does. However, that doesn't mean the risk is non-existent. That multiplier becomes dangerous when the baseline risk is already elevated.
Ah.
The risk of stroke compounds dramatically if the patient has been on the pill for a very long time, if they're taking a high estrogen formulation, or most importantly, if they have other vascular risk factors.
Like what?
If a patient is over 35, has diabetes, hypertension, or if they smoke cigarettes, the baseline risk is much higher. Multiplying that risk by 9 is when the math gets genuinely dangerous. And it's why doctors carefully screen patients before prescribing estrogen.
That makes perfect sense.
Yeah.
Now, speaking of things that require careful screening and context to understand, we really need to discuss sickle cell disease.
Yes.
Because the medical understanding of how sickle cell causes strokes has gone through a massive paradigm shift.
It is a prime example of why assumptions in medicine, even when they sound perfectly logical, have to be tested against actual pathology.
Just looking at the demographics of sickle cell strokes reveals a lot. Children with sickle cell anemia usually present with ischemic strokes, so blockages.
Right.
But when adult sickle cell patients have strokes, they are far more likely to suffer from intracerebral or subarachnoid hemorrhages, basically catastrophic bleeding in the brain.
And that's because the nature of the stroke changes as the vascular system ages. Decades of chronic damage weaken the blood vessel walls until they eventually rupture under pressure.
But let's focus on those childhood ischemic strokes, because this is where the medical community got it wrong for a long time.
They did, yeah.
It seems incredibly intuitive, right? Sickle cell disease causes red blood cells, which are normally soft and flexible, to become rigid, hard, and crescent, or sickle-shaped.
Yes.
The logical assumption was that these hard, sticky cells were just sludging up the tiny, microscopic capillaries in the brain, just a microvascular traffic jam.
It makes total conceptual sense, but when pathologists and radiologists actually looked at the vessels of these children, they found the exact opposite.
The reality is that sickle cell strokes are primarily a large vessel arterial disease driven by a process called intimal hyperplasia. To bring back our highway analogy, the assumption was that the hard sickle cells are getting jammed up in the small, winding side alleys of the brain. But the reality is that the concrete of the main multi-lane highways, the major intracranial arteries, is actually thickening, expanding inward, and closing down the lanes.
That is the perfect way to describe intimal hyperplasia. Those rigid, sickled red blood cells don't just sludge up, they act like microscopic sandpaper.
Sandpaper, ouch!
Yeah, as they rush through the major arteries, they constantly scrape against the delicate inner lining of the blood vessel, the endothelium. This constant physical friction causes chronic inflammation.
Okay.
And in response to this unending injury, the smooth muscle cells in the artery wall begin to multiply and grow thicker to protect themselves.
So the pipe literally narrows itself trying to heal from the friction.
Exactly. And as the main arteries slowly choke off the blood supply, the brain desperately attempts to grow tiny, fragile new blood vessels to bypass the blockage.
Which you can actually see on a scan, right?
Yes. On an angiogram, this chaotic tangle of tiny collateral vessels looks like a hazy cloud. It's often described as a moya-moya-like pattern, using the Japanese term for puff of smoke.
That's haunting. So you have these major arteries silently thickening inside the brains of young children over months and years. How on earth can doctors predict a stroke before a devastating event occurs? It sounds like a ticking time bomb.
It is, but this is where medical engineering provides a way to see the invisible. We use a tool called transcranial Doppler ultrasound, or TCD.
TCD is completely painless and non-invasive. It's just sound waves. But how does a sound wave tell you an artery is narrowing?
It's pure fluid dynamics. Think about a garden hose. If you want the water to shoot further across the yard, you put your thumb over the end of the hose, narrowing the opening.
Right.
The volume of water is the same, but because it has to squeeze through a smaller space, it shoots out at a much higher velocity.
Oh, wow. So as that intimal hyperplasia narrows the arteries in a child's brain, the blood is forced to travel faster and faster to get through.
Precisely. The TCD ultrasound bounces sound waves off the red blood cells. By measuring the frequency shifts of those returning sound waves, the machine calculates the exact velocity of the blood.
That is incredible.
It really is. It can literally hear the blood moving too fast, identifying the highest risk children weeks or months before a vessel completely closes off.
And once you identify a child at extreme risk, doctors intervene with chronic blood transfusions.
Right.
The goal is to dilute the sickled cells and keep the abnormal hemoglobin S levels below 30%, essentially removing the sandpaper from the bloodstream.
Exactly.
Which leads us to a landmark moment in clinical research, the stroke prevention trial in sickle cell anemia, widely known as the SADO-P trial.
It is one of those profound moments in medical history that changes standard of care overnight.
So the researchers were conducting a randomized trial. One group of children at high risk, based on their TCD ultrasounds, received standard care. The other group received these proactive chronic blood transfusions, and the trial was designed to run for years to gather data, but it was halted early. Now, usually an early halt means the intervention is toxic and people are getting hurt, but the SADO-P trial was halted for the exact opposite reason.
It was stopped because the data became overwhelmingly undeniable.
Wow.
Yeah, the children receiving the chronic transfusions saw a massive, immediate reduction in their stroke incidence compared to the control group. The intervention worked so decisively that the independent safety monitoring board had to step in.
You can just imagine the emotional weight of that room. The researchers realized they had a moral obligation to halt the experiment immediately.
Absolutely.
Because continuing to randomly assign children into the standard care control group, effectively withholding the transfusions they now knew for a fact could save them from a stroke, was just no longer ethically defensible.
Exactly. They couldn't just watch kids suffer for the sake of finishing a spreadsheet.
It is a stunning victory for medical science.
It is a reminder that data is only as good as our willingness to act on it to prevent suffering. The ability to monitor these vascular changes changed the entire landscape of sickle cell care.
Definitely.
And just to round out our exploration of these extreme blood disorders, there is one more rare condition worth noting from the file that operates purely in the microcirculation, and that's thrombotic thrombocytopenic purpura, or TTP.
In terms of mechanisms, TTP is almost the inverse of what we just discussed with sickle cell, right?
It is. TTP is a life-threatening microangiopathic condition. Patients lack a specific molecular scissor, an enzyme, whose job is to cut up large, sticky strands of a clotting protein called von Willebrand factor.
Okay, so they are missing the scissors.
Right. And without these scissors, these long, sticky strands act like microscopic clotheslines strung across the smallest blood vessels. As red blood cells are pumped through these vessels, they literally get sheared apart on these strands.
Oh, man. And the physical destruction of the cells causes severe anemia, dangerously low platelets, kidney dysfunction, and fluctuating neurological symptoms.
Yes. It is a massive emergency requiring intense treatments like plasma exchange to replace those missing molecular scissors.
It perfectly illustrates how incredibly complex and fragile the ecosystem of human blood truly is.
It really does.
When we pull back and look at the big picture of this deep dive, the statistics are telling. Hypercoagulable states, these genetic oil slicks, the hidden cancers, the autoimmune attacks, they explain only about 1% of strokes overall across the entire population.
But in young patients, they account for 2 to 7% of ischemic strokes. And more importantly, they account for a massive chunk of cases where doctors initially look at a young, healthy patient and have absolutely no idea what went wrong.
It proves that true medical detective work requires looking far beyond the usual suspects of age, diet, and blood pressure. You have to investigate the environment, you have to check the invisible chemistry.
Absolutely.
Which leaves us with a final, provocative thought to mull over today. Think about that transcranial Doppler ultrasound used for sickle cell patients. It is just a simple, non-invasive sound wave, but it can literally hear a catastrophic stroke coming months before it actually happens, just by detecting a subtle change in fluid dynamics.
Yeah.
It makes you wonder, what other catastrophic bodily events are silently telegraphing their arrival right now, echoing through our tissues or our arteries, just waiting for us to invent the right microphone to tune in and listen?
That's a great point. The physical signals of disease are almost always there before the symptoms arrive. We are just scratching the surface of our ability to hear them.
Well, until we invent those new microphones, we will keep following the evidence we have. Just remember that 25-year-old stroke patient we pictured at the start. They aren't a broken rule of medicine, they were just a different kind of mystery, waiting for the right detective to solve it.